And it's important that they feel like they can connect to you, even if you have opposing views and opposing beliefs. So that's what we're talking about when we talk about this. We want to be able to make that connection. Now, the steering committee members of the California Mental Health and Spirituality Initiative also were providing guidance to these 3 counties during this time that they were creating their policies and procedures. So when we saw these, we thought, oh, these are great models to take a look at, right? So some of what's in our policy and procedure is modeled after these other counties that came before us. So it's kind of the idea too, is like, we don't need to reinvent the wheel, right? Like we can, try to build on the wheel that's already there. So going into just, so first of all, how many clinical providers do we have in the room? MFTs or psychologists or LCSWs, any other types of providers, nurses? I heard that there was a ton of nurses everywhere. Okay. I was like, wow, it's like a nursing convention. Yes, okay. All right, so yes, we have quite a, we've got a few in the room. All right, so as we all know that, we get trained on the Diagnostic and Statistical Manual for Mental Health Disorders. The current edition is like DSM-5, I think TR now, like I think that's where we're at. So this, we gotta update our slide, but so anyway, the point of this slide is just to say that that manual also the importance of having a cultural formalization is codified in there, and that we're supposed to be using that. And that type of formalization includes cultural identity of the individual, which has got multifaceted. So we're looking at racial, ethnic, cultural references that could be influencing the client's relationships, and also with others, and access to resources and development and current challenges, conflicts, and predicaments. So the extent of assessment that we're doing, we want to try to be looking at all of these things. Other relevant aspects of identity can also include religious affiliation, social economic background, personal and family places of birth and growing up, and migrant status and sexual orientation. And also, of course, we're looking at our psychosocial stressors, cultural features, and vulnerability and resilience, which, there are some key stressors that individuals face in their social environment. And we also want to look at the role of religion, family, and other social networks that might be providing emotional support to the client. So again, this is just reinforcing that we want to have really comprehensive assessment of our clients, which include these explorations of religion and spirituality. So we can go ahead and go to the next slide. So now, again, we did a lot of research, so some of these slides are getting into that here. So looking at those spirituality policies a little bit more, for Los Angeles County, they did a pretty in-depth study where they looked at a bunch of their wellness and recovery centers. So they actually reviewed 53 of their centers. And so this is what their findings were. So they had 98% of those centers offered options for spirituality infused activities. 33% of them offered spirituality focused groups. 80% of over 2,000 participants in their study, and that's a pretty good sample. Those researchers in the room, that, right? That's a good sample. Those participants agreed or strongly agreed that spirituality was really important to their mental health. And then some of the things that folks said they were doing were prayer, meditation, attending religious services, spending time in nature, and reading sacred texts and spiritual or self-help books. So that's what they were finding. So again, very important to our client populations that we work with. I feel like I saw a hand. Did you have a question? Okay. Saw this. I was like, okay. All right, so we go to the next slide. All right. So, so more about the study and the review that we were doing. One of the things that the team also looked at was spiritual and religious competencies that they wanted to see in the practitioners. So one of the studies that they found was where we saw that the majority of psychologists were basically saying that they didn't have enough training in this area. So very much like that idea of division of church and state, right? In our field of psychology, when I was trained, one of the things that they would say to us is that, okay, you're not a priest or a religious practitioner, and if the client needs that, we need to get their spiritual person involved. Like they would basically tell us, no, you're not going to go there. So that's changed a lot in the last 20 years, right? So and I think that's good that that's been changing. So we also find that some of the proposed competencies should be around the attitude, knowledge, and skills of the providers. And they also found, our team also found what's known as a FICA tool. We'll talk a little bit about that in a minute. But this is a tool that's supposed to help aid clinical assessment of spirituality. So it's kind of like a how-to go about this kind of conversation. And it addresses spiritual needs and concerns in the different clinical settings. Okay, all right. Sorry if that's hard to read. I thought it looked better on my computer, but maybe not. Okay, there's a lot of words here. I'm not going to read all of them. These are quotes from some of the studies that the work group found. So, the first one talks about how religious beliefs and practices can be very powerful sources of comfort, hope, and meaning. Now, but it also has another side to that for some clients, and the other side is that it also can be entangled with psychiatric issues, okay? And it can be sometimes difficult to determine whether or not the spirituality or religious beliefs are helping or harming the client. So this gets to like being very open when you're talking to a client. Be careful, don't make assumptions about what the religious belief or spirituality is doing for that person. Now, most people, it seems to be helpful, but there are some people where it really is not. So be careful when you're talking to your clients. Results showed that both religiousness and spirituality were significantly associated with proxies of well-being and symptoms, but not to goal achievement. Another finding from the research was showing that religious affiliation does not necessarily protect against suicidal ideation, but what it does do in a lot of cases is protect against the suicide attempt. So it's having an effect on behavior. Whether religious affiliation protects against suicide attempts may depend on the culture-specific implications of affiliating with a particular religion, since minority religious groups can feel socially isolated. So again, going back to, it can go in many different ways for the client that you're working with. Another finding that we had from this research is that religiously unaffiliated subjects, so what it's talking about are people that don't have religious or spiritual beliefs. So those folks, they significantly have more lifetime attempts and more first-degree relatives who committed suicide than people who had religious affiliation. Also, unaffiliated subjects were younger, often less married, typically had less children, and had less contact with family members. So when I think about that, I wonder, okay, is it because a lot of times when we have religious groups, right, there's a social aspect to that. So perhaps what's happening for some folks is that they're like almost like have one less way of communicating with their family or something to group themselves around. So then we're seeing more isolation. So let's go to the next slide. And so an additional research that we did on, again, religion, spirituality, mental health, and suicide is that we are also finding that existential spirituality and self-forgiveness may be the protective factors that can actually help prevent suicide behavior. So this is the thing that's keeping people from actually hurting themselves. So they forgive themselves, and they have this sense of meaning in life and what they are here for. And that's the major protection. So again, when we go back to that safety planning and making sure there's something that they have hope for, it's a big deal. And that could be tied to their spiritual beliefs or their religious beliefs. Spiritual care providers should be part of the client's treatment team. We've already kind of covered that, but I think it's very important to include them. And non-affirming religious beliefs are associated with higher levels of depression and suicide risk for LGBTQA+ clients. So again, major point here, this is a group of clients and also people that have been persecuted for religious beliefs. Their group or their experience of religion and spirituality is very dependent on whether or not those systems were affirming them in their identity. So it matters a lot. So we need to check when we're talking to those groups of people. All right, so this is the next slide, is about this FICA tool. So this is what we've worked into the policy and procedure, so we have this referenced. One of the articles that we found did show from NIMH, from National Institute of Mental Health, showed that folks do actually talk to their clergy quite a bit, like 23%, 16% to their mental health provider and their medical doctor. And so that was one of the reasons why we felt that it was important that, it seems like a lot of people do talk to different folks in their lives. And so we want to make sure that assessments are also including this important thing. So taking a spiritual history is important for the assessment, as I've been saying. Most American patients report that they want medical professionals to be aware of the importance of religion or spirituality for them. And that also the FICA spirituality history tool was developed to help healthcare professionals address spiritual issues with patients. And it serves as a guide for the conversation, as I said before. It's used to help identify spiritual issues that patients face, spiritual distress, and spiritual resources and strength. The acronym, this is what it stands for, so faith or beliefs, importance or influence, community, and addressing the beliefs. Go to the next slide. Okay, we're almost done. Okay. All right, last part that we have here is, and I also think a very important part is, this is what's a summary of what's included in our policy and procedure in terms of how we would like to help guide our clinicians. So the staff, we're really wanting clinicians and folks that are doing these assessments to interact in this way. So we want to really encourage that all providers to explore spiritual religious beliefs, starting with that initial assessment. So it should be just incorporated into the assessment. Using an unbiased approach, as I've explained before, when we're exploring is very important, okay? Holding a caring and safe environment, that's important. Following the client's lead regarding how much to talk about spiritual or religious beliefs, so really paying attention. If they want to stop, we stop, right? Okay. And then also not assuming having religious or spiritual beliefs is either helpful or harmful, as I mentioned before, that we have clients, especially in our county, we have a very diverse county. We have clients who have gone through rejection, ostracization, and exclusion due to sexual orientation, gender identity, race, culture, and factors. So again, we need to be responsive and be sensitive and supportive when we hear about this. Another thing that we want practitioners to be very mindful about is that some clients may not have a spiritual or religious belief. Again, that's okay too. So if we find out that's the case, then again, we might stop that conversation. Emphasizing that staff is not to impose their beliefs onto the client. So that's another piece to this. We have to be very, recognize that our beliefs should not be pushed onto a client. So it's very important that we don't do that. Okay, go ahead and do the next slide. And any comments, questions? I know that was a lot of stuff. I think you'll be getting a copy too of the slides. Okay, thank you. Oh, okay.
Oh, all right.
Oh, do you need the microphone? Right.
Oh, yeah.
They want everybody to go into the mic. Yeah.
Hi, thanks. So working with an individual in a clinical situation or even in a counseling situation, if you're confronted with a religious or spirituality that you're unfamiliar with, should we stop? Say, oh, I don't talk about, I don't know that, so I don't talk about it, or do we defer and say, look, I need to get more information? I mean, do we try and fake it and just assume that we understand that they have a religious or spiritual practice?
Well, and because you all are welcome to help me out with this one, but my thinking is that just be like any other thing about clients that you're not familiar with, so clients can also tell you about cultural aspects too that you may not be familiar with.
Right.
So the way I would typically think of that is allowing them to tell me their experience. And then I'm gonna, after that session, go look some things up, right? So I'm gonna go look up that religion or spiritual belief so I can learn more about it, so I can be a bit better prepared. But remembering that even when I look all that stuff up and we do all of our studying, that everybody has a different experience, and what you read about may not be your client's experience. So it's still important to get that from them, but in a very supportive, sensitive way. So again, go with what they're feeling comfortable sharing at that time is fine. You may not get everything that you're looking for, and that's okay too. They'll probably tell you more later if they're comfortable enough to do that. So that's my thought on it.
I'm just afraid of the words, if my Christian background where we prayed and we practiced, and if the client talked about prayer but their religion is completely opposite, that I might interpret, I might assume. So there's the next. So don't assume,
that's the
right?
piece. Yeah, that's the hard part, right? That's always the difficult part for any of us, is trying to keep our own bias out of the room. How I explain it to my students is that I walk in that room and I leave whatever I'm concerned about outside the room as much as possible. I focus 100% on my client, and I just try to be present with them. And that's what helps me keep whatever else is going on in my head out of that room in that time. And then I will have my thoughts later too. But when I'm there with them, it's all about being present. And I find that seems to work, at least for me. Any other thoughts on it though? I mean, we've got all of our experts up here. So, okay. There we go. Anything else?
Any other questions for Renee? All right. Yeah, this is definitely a complicated topic. And when the suicide prevention stakeholders first approached me saying, we want to do a behavioral health spirituality policy, I am not a clinician. I do not have a religious practice. And so I've learned a ton from working with the different stakeholders, Mary, Renee, NAMI FaithNet, about this topic. And it's so layered and complex. It's really fascinating to me. There's another question. Okay, go ahead. Oh, I'll get you a mic. You can have mine.
It's just I've never heard of California Mental Health and Spirituality Initiative. Is that searchable online, or I thought you mentioned that? Yeah. You said California.
No, we're talking about the background, the strategic plan, the California strategic plan on reducing mental health stigma and discrimination. You're talking about that? It was from 2009?
I thought you mentioned a place called the California Mental Health and Spirituality Initiative earlier. Did I miss that?
I know about that.
No?
I know about that. It's a group of people, and they meet monthly on Zoom now. It's a collection of all kinds of people, faith leaders, and they are trying to get rid of the stigma and discrimination around mental illness and educate faith communities.
Okay.
But
So if I just search that, I'll find them.
if you don't, you can contact me. I have the
Okay, maybe I
contact
could
for
get
it.
your card
Yeah,
later.
we have people who attend that.
And I have a couple spirituality mental health resources to share from San Mateo County, if that's appropriate later. Yeah. Okay.
All right.
Thank you.
Are you with NAMI?
I think there was another question.
Yeah. Oh, there's another question?
Yeah.
Okay.
You mentioned like reaffirming their spirituality, but how do we approach it if their spirituality or their religious understanding says that if they commit suicide or someone they love has, they're going to hell? Do we reaffirm that? Do we counter that?
Yeah, so there's a lot of Christian, usually a lot of Christian, it may not be the only type of religion that does this, but there's a lot of Christian religions, right, that have that. Now, when we're trying to stop someone from harming themselves, it actually is a protective factor, right, because it's stopping them from doing the behavior. Now, obviously, it also may initiate shame around the acts, like their attempts, that sort of thing. So that's a very, I would say, a sensitive conversation we're going to have. But what we don't want to do is take away something that's stopping them from actually committing the act that could kill them, right? So we do see it as protective. Go ahead. Right, so that's kind of like the groups we were talking about earlier, like some of our unfortunately, some of our LGBTQ plus clients, they've had religious experiences where they were not accepted, so it created a lot of pain for them. So that's a good example of what you're talking about, or it's making their life worse in other ways. Maybe it's a religion that says, you keep your marriage going no matter what happens, or that's their interpretation, right? So there's a lot of different harms that can occur. And so the way I think of it is that then I am going to get into a type of conversation to try to see if I can shift their thinking and see if I can help them see a gray area in their beliefs, because I want to get them out of that harmful scenario. Like, if it's an abusive marriage, for example, I'm not going to want to, encourage them to stay in that environment. So it's going to depend. And I think every practitioner might go about this differently, but that's kind of my thought. Other thoughts, folks, on that? It is a bit tricky, right? So. They're not clinicians, so sorry. That's my instinct on that. Like how I would go about it. So again, I want to encourage flexible thinking, right? Really try to be as flexible as you can as you're sitting with your client, and recognizing their safety is your number one priority as a practitioner. That's always my number one priority, is keeping them safe. Okay. Yeah, go ahead.
Based on working with my elder clients as well as my own family members, and what a woman told me here today who's a therapist, not here, but somewhere, one of the sessions. She's in her 60s, and in her townhouse complex, a 30-some-year-old would park his car in front of where it wasn't supposed to, near her place. When she said something, he said to her, "You're just old and you need to find purpose in your life." So when she told me that, I was thinking about, spirituality. I wish there was somehow incorporated into the spirituality, addressing how elders, when they get to that age where death is imminent or people start ignoring them or pushing them aside, that part of the suicide prevention is helping to bolster their self-confidence or their worthiness, and I see that. And now that I'm older, I also see it, the lack of respect. And I don't see that addressed somehow intertwined into the suicide. You know what I mean?
Yeah, no, I think that we are in a culture where ageism is quite rampant and very problematic. So to me as a clinician, if somebody's coming to me and their self-worth is being damaged by that, then I'm likely going to do core schema work with them and try to help them with the way they cope. But also, like, if there's actions that maybe, like problem solving, if there's any action they want to take, every client's a little different as to what will maybe help them feel better. But maybe even advocacy, if that's something that somebody would be wanting to do, because there's definitely social issues in our culture that really are devaluing older adults in a way that's just terrible,
And
you know.
it is happening in the medical field. We don't have many geriatricians, right? And I've had volunteers at the senior center where I work tell me that when they've heard comments, when they're working with a doctor or a nurse, it really devalues them. And I've never really thought to ask about the suicide, actually, even though I've had clients commit suicide. But I think that's just kind of rolling in my head, the disconnect of the aging society, which is growing, and the lack of addressing discrimination and how do they fit in a society that doesn't want to address it.
I know I agree that we need more gero practitioners. One of my specialty areas is working with older adults, and the folks I trained under, they actually had coping with depression for late life depression type therapy that we trained in, and part of that was literally working with medical doctors for older adults because they were having problems like what you're talking about. And also with that team many years ago, they were part of Stanford Psychiatry. They were doing bedside manner training because it was a concern, like we were concerned. So this is something that, yes, and I'm sure it's going on today. I mean, we need more training around that. We need every practitioner to be careful and sensitive as much as they can. Because it does a lot of damage when somebody feels like they're being ignored or they're just being shooed out of an office or whatever's going on there. They can't get something out because they're not being listened to. So literally that approach actually had, interventions like broken record and all kinds of interventions to help them deal with it. So because, it's a major issue. But thank you for raising it. Go ahead, Mego.
I'll just add that that's what you're describing is precisely the reason that our county suicide prevention program, we've developed an older adult suicide prevention subgroup to really focus in on this topic. Because what you're talking about is building up protective factors, right? And older adults can be seen as their own specific cultural group with their own specific needs. So whether the protective factor is building up spirituality, if that is seen as a protective factor for that individual, or a sense of purpose, connectedness to the community, that worker's really working on those kinds of things.
I didn't know there was a component.
They did present earlier today too, so maybe you can catch the recording too, after the conference. But thanks for raising that. I do want to make sure we have time to highlight NAMI FaithNet, so I'm going to go ahead and introduce Kathy Forward, who's a family member with several family members who've been diagnosed with mental illness. Since 1997, Kathy was in the first Family to Family, The Keys to Understanding class for families in Santa Clara County dealing with mental illness. And since then, Kathy's become one of the principal leaders at NAMI Santa Clara County as a volunteer teacher, trainer, and eventually education director. Then in 2010, she became the board president and served as the executive director for 6 years. So Kathy's worked closely with numerous mental health organizations over the years, always with the goal of helping those organizations understand that family and peer support are critical elements for a person struggling with mental illness. So Kathy's going to talk about development of the FaithNet program and how they worked to create what they call mental health friendly, stigma-free congregations. So go ahead. You don't have slides,
I don't
right?
have slides. You just have to hear my voice. Sorry. So we are a family and peer-run organization. I like to tell people that, we come from all walks of life. We're not clinicians, but we do have clinicians amongst us. And so we approach things through education and support, and we train people to become advocates for themselves and others. So two family members, Dr. Gunnar Christensen from Los Angeles and Reverend Chet Watson. He was from Contra Costa County. He's passed away now, but they were family members, and of course he was in the faith business already, and they decided that we know that 90% of people who have any kind of issues, they'll go to their faith leaders before they go to anyone else. And he being a faith leader and Dr. Christensen being a strong person in his faith community, decided to start this FaithNet. It wasn't called that yet, but they started going to NAMI conferences, California conferences, and having workshops and talking about the importance of educating faith leaders about mental health. Just like if someone is coming to a faith leader and they are showing signs that they're starting to have a heart attack, they most likely would not say, I'm going to pray for you. Or, I'm sorry, we don't like your behavior. You have to go somewhere else, or you have to leave this congregation because of your family members' behavior. They wanted them to understand, what about mental health and recognize it, not diagnose people, but have resources and be able to refer people out. So I think FaithNet kind of came into being. This was in the early 2000s they did this. So I want to say maybe around 2008, somewhere around that. NAMI National did coin it as FaithNet, and there's something on the national site, nami.org. And there's a presentation and there's some basic information, but they kind of called upon NAMI affiliates to do the work that we do to take this on. And of course, many NAMI members belong to faith communities. And so this is how it started. We started it in our affiliate. We felt that strongly that it should have a faith leader in our affiliate who has a mental health condition. Like I said, we have everybody, all walks of life, all kinds of things. So we found Reverend Cindy McCalmont. She was actually involved with us in developing our peer mentoring program. And she's an ordained Methodist minister who had her own mental health challenges. Again, ostracized from her community in the Midwest and moved to California for her recovery. And, I found her and I asked her if she would be willing to start our FaithNet outreach. So she agreed. And we approached it with, again, we had many, many family-to-family classes by that time. And this was probably 10 years ago that, I started working with her. And then we started the FaithNet outreach maybe 8 years ago. And so we knew we had lots of people who had taken our classes, peer-to-peer recovery education, family-to-family, and even the provider education course. So we started reaching out to all those people and asked them if they were in a faith community, would they please bring someone from their faith community to a lunch at our office to learn about our resources, to learn that they're first responders and how important it is to learn about, mental health. So that's what happened. And we had these lunches quarterly, and people came and they brought, youth ministers, different people. Several of them were from the Catholic churches around here. And so basically within 5 years, I know the Catholic Church and, the diocese here, the bishop has written a 10-page proclamation about the importance of having, recognizing mental health. They have started mental health ministries. And so, we knew that this was working, and we were fortunate enough to get an innovation grant from the county to expand this effort and reach into underserved communities. So we had that grant for 3 years. We have reports on it, and to reach out to also underserved communities. So we hired several people, from underserved communities, and we took a presentation that NAMI California had called Mental Health 101 and adapted it as a team. And of course COVID hit. We got the grant in 2019, so we had to go online. So we adapted to Zoom, and we did these presentations once a month, and we invited faith leaders from all over. And then when things opened up, we started doing them in person. And we also developed a brochure, and we call it Becoming a Mental Health Friendly, Stigma-Free Congregation, as Mago said. And if there's 24 ideas in the brochure of things that people can do. And we've categorized it by be aware, be educated, be vocal, and be empowered. And there's about 5 or 6 ideas under each of those categories. And because we don't have a magic formula like, oh, you do A, B, C. Every faith community has their own beliefs, their own ways of practicing. And so it's up to them to develop this mental health ministry the way that it fits into their faith community. So basically, once they complete 10 of those things, and it doesn't have to be these things, they might come up with something different too, then we give them a nice decal and a proclamation, a certificate, and we put them on our website. And so we have about 23 or 24 faith communities. We have several that are kind of in the works that we're working with, that if somebody is looking for a mental health friendly faith community, maybe the person that you're talking about, you're treating is feeling this in their faith community, and you want to encourage them to look around and check out other communities. And they're all different faiths that are starting these. So that's basically, what we've done. And unfortunately, Cindy left to go back to the Midwest. Her husband got a job on the East Coast, and she's got 4 grandchildren in Minnesota, so that's where she is right now. So we're going to be looking for a new faith leader with some mental health lived experience, because we feel that's really critical. And Cindy was also able to reach out, join a lot of interfaith groups and other faith leaders, because many faith leaders have mental health challenges and they have very hard jobs, right? And they don't talk about it, and the suicide rate is high in that community as well. So she also started working with other faith leaders in the work that she did too. So that's the premise of FaithNet. We have on our website more details. We do this Mental Health 101 presentation. We're going to have one in November. If anybody's interested, it'll be on Zoom. We found that Zoom is what people want with meetings now. Is that right? For the most part, unless you have a full day planned like this. But so it's a very good idea. It's working. I think if there's a silver lining to COVID, that we all have mental health. Hopefully everybody knows that now. Everybody's talking about it. Let's keep that door open. We don't want to go back. And the other part of our grant was I'm so happy to see your presentation today, is about the clinicians, again, acknowledging faith, and how can we bring the faith leaders and the clinicians together. And if somebody is we think a team should be treating people, that, and we're always begging for families to start being included in that model as much as possible. That's about a big part of what we do, because we know that people do better if they have a treatment team and everybody's working for the health and wellness of that person. So, you could find out if that faith leader is interested in becoming part of that team, and how you can work together to support this person's mental health. So that's it for me.
And Kathy, you have some
Oh,
materials
I brought
here, right?
brochures up here too. So, I have the basic FaithNet brochure. I have the 24 ideas, another brochure, our county brochure, so you know all the services that we have, which are all free to the community, by the way. We don't charge for any of our classes or support groups or anything that we do. And then also we have a provider education course that the county does fund, and it's about having a collaborative model of care that does include the families. I encourage any clinicians here, you might be interested in taking that too.
Any questions about NAMI FaithNet or for Kathy? Yeah, go ahead.
I see one of your points under Be Vocal is join National Prayer Days for Mental Health and Suicide Prevention. So we actually have in San Mateo County National Day of Prayer on October 10th, and I have flyers in English and Spanish. And we also we have our spirituality initiative, which is open to all faiths and practices, because our annual clinical surveys say that 80% of clients want to talk about their spirituality, but less than 20% get to. So over 10 years ago, we founded the Spirituality Initiative. So, and I'd like to get your card and communicate, and possibly your slides too. So, yeah, thank you for recommending that. So,
Yeah, thank you. The San Mateo policy was one that we based the Santa Clara County policy very much on. And we spoke to some of the people from your initiative in the beginning. No, I can't remember now. It was years ago. Yeah. I guess it, oh, go ahead.
I don't know them offhand, but you can find the ones that are certified on our website. And we're working with a couple of synagogues right now, so.
Kathy, I was wondering if, could you speak to some of the challenges NAMI FaithNet has had with engaging faith leaders, if there have been any?
Actually, I think the group of people that we had hired for the grant, they had pretty good success in talking to a lot of their faith leaders. I think Santa Clara County, we do live in a probably more progressive county in some ways too. And also because we're such a diverse community. So like the Catholic Church, they have several, factions of groups, and some of them are doing their own kind of ministries with their mental health too. So, yeah. But I think the Mental Health 101, the basic kind of overview, and talking about how religion can be a positive factor, can be a negative factor, and we also talk a lot about the Dr. Xavier Amador's book called "I'm Not Sick, I Don't Need Help." They use this method of listening and partnering with people that don't see that they have an illness too. So. And they're very interested in working. And I can tell you one story of, one of the ways we got into the congregation. We did the Mental Health 101 with some of their staff, and then we have an inner own voice presentation where people share their stories of wellness and recovery, what happened to them, what helped them, and what their future, what they're hoping for. And so this church we were working with, they were pretty far along with becoming certified, and they did this in our own voice presentation for their congregation. And it turned out they had a very active member who had a very serious diagnosis. She'd been there like 30 years, never told anybody. And she became the real integral person to get this ministry going, because it does take, we work from not just the top, but the bottom and the top. You got to work, you got to have a team. The ministers are busy, they've got a lot on their plate. But a lot of them, as I said, have mental health conditions themselves. When they give a sermon about mental health, they talk about their own lived experience. They find out 1 in 5 people are sitting right in front of them that want to talk about this, that have been in the shadows and, want this ministry. So they become active members in their church for it.
Thank you. All right, any final questions? Otherwise, we'll end a couple minutes early. All right, thank you so much, Renee, Kathy, and Mary. Let's give them a round of applause.